So just want to take a minute to thank Joyce Fillenworth and David Conrad for all the work they're doing there at the State Office of Rural Health and helping to support the call center. I know that Joyce has been distributing several emails about some different grant opportunities and potential funding available for hospitals. So please make sure and take note of those email distributions that she's been sharing. I think there will be some things that you are interested in. This is Becky Royer, and I'm contracted by the State Office of Rural Health to assist with the Medicare Beneficiary Quality Improvement Project work, which our Swingbed initiative is a part of. We have several that have joined, and I did distribute some materials that Kerry is going to be referencing earlier this morning, so please pull up that email from me. And at this time, I'll turn it over to Kerry Dunning, our Swingbed consultant that's done a great job of providing some key updates for the Swingbed programs and, of course, most recently, the COVID-19 pandemic. So, Kerry, I will turn it over to you.
Thanks, Becky. I appreciate it. I'm going to try and get through these main topics in time to leave a little bit of room for questions if there are any. It is an extraordinarily fluid situation. I go to bed usually with CMS dropping something in my email, and I wake up with usually CMS dropping something in my email. So they are working overtime as well. And I actually want to compliment that whole team at CMS, the people with the skilled nursing facility and long-term care division that I've worked around for years and years, and they were thrown into the fire with all of us. And they, if you don't know, they have office hours on Tuesday and Thursdays at 5 p.m. Eastern, where you can call in and they'll answer questions. And they have been doing that routinely now for several weeks. So they're trying very hard to keep up with all the changes. So let's start with the first one here. What you have to remember is, even with all the waivers, we still have to follow the rules. So for instance, I've had 3 calls this week about people that probably didn't meet skilled criteria, but there was no other place to put them. Could they just put them in the swing bed? And the answer would be yes, but you can't bill Medicare. We still have to meet that criteria. They still have to have one of the main areas why we would use skilled nursing, which has to do with the nursing categories as well as therapy or rehab component to it. And remember also that the only way you can use a waiver or any of these rules that are sort of breaking the rules is if you are in the middle of COVID-19 in your immediate area. So as it peaks and troughs at different times around the country, some of you may, even inside the state of Indiana, be in it, and others have come through it, and others may hit another piece of it. So for instance, I have several sites out west that early on, actually very early on, had COVID-19 acute patients. They sort of finished that up, and now they're seeing COVID-19 swing bed patients. So as those cycles go, you're going to have to pay attention to your own region and just be aware that all these rules that we're going to be talking about today are specific, well, except for the second one I'm talking about, that all the rest are specific to an emergent situation, a pandemic. And I was reviewing a policy for actually a program in Indiana this morning, and it reminded me of something, which is you may need to update your admissions criteria and may need to put a one-line disclaimer there at the very top about there are some things that are specific to when there is a pandemic. And I would actually list it as a pandemic. We've had other pandemics in this country since 2000, I think 2 of them, maybe 3 of them since. Let's see, we had SARS, we had H1, we had what was the other one? Ebola. So we may have had 3 pandemics. This just happens to be the one that's kind of impacted the whole world, literally shut down the whole world. So you might want to put in saying that there are variations that can occur during a pandemic. So just heads up on that. The next thing, and I sent this out to Becky and she has forwarded it to you, there are 2 assessments that I think you need to complete. Remember that while CMS is suspending the rules in so many areas right now, every time I have been through anything, including I had clients in and around New York City after 9/11 where things were suspended. They always came back within that year and reviewed multiple sites. The survey system for long-term care, skilled nursing, actually for our swing beds is suspended as far as routine surveys right now, but they are doing infection control surveys. So one of the assessments that I've sent to you is from CMS, and it is a review of your infection control policies. There are over, I don't remember the total number right now, but the numbers that are nursing homes in this country that are impacted already by COVID, we're not even hearing on the news. I'm not sure why, but any one of those, if we have COVID-19 patients and we have some kind of outbreak within a facility like a nursing home, those are the ones that are probably going to get surveyed very quickly. So make sure you're ready for that. The second is this, by pandemic definition, this just triggered our emergency preparedness rules, and it triggered an Indiana state pandemic rule. And I have told you before, I don't memorize all the state rules, but if you're not aware of what's in the Indiana pandemic emergency preparedness plan, you probably need to talk to whoever's in charge of that particular job within your system, because he or she will know what the state requires. And then you'll have your own, but then there's a subset of that, because there are things that are acute, and then there are things that'll be post-acute or for your swing beds. So the second assessment, actually CDC, I think, is the one that put it out, but it is specific to emergency preparedness. It's very complete, and actually I've had people that have updated their emergency preparedness almost every year now, because as you know, I live in the Southeast, and we've had these just gigantic hurricanes, 3 out of the last 4 years, that have covered the entire Southeast, sometimes at once. Michael covered all of Florida at once, so it took away our transfer rules. We had no place to transfer patients because Georgia was getting hit, South Carolina was getting hit, and there was a chance that Mississippi, Alabama, and Louisiana could be hit by it when it was coming up. And so the closest place we could have taken any nursing home patients from Florida would have been to Tennessee, which was obviously not practical. So we've had to amend ours pretty routinely. So I would suggest that you look at that, and I'd suggest you complete both of these assessments. We have talked about the 3-day waiver. There has been a lot of questions. What's really interesting is it's come up over and over, and on the last, I think it was a stakeholders call, CMS said they didn't know, they'd have to look into it. Since then, at least 2 people I know have gotten letters from CMS. One went to the National Rural Health Association. One went to one of the system hospitals actually in Indiana. 2 others, one in Arizona and one in Mississippi, say they have verbal comments from CMS, but nothing in writing. And then mine's floating out there where I got a reference number, and it has not been answered yet. What's interesting between the 2 letters that I have seen, they're actually different. They were written by different people within CMS, but both agree that critical access hospitals can indeed waive the 3-day required stay, which is nice to see 2 things in writing. If I get mine back, I hope it says the same thing, because it says something different, then I got to go down to the rabbit hole. So what does that mean? That means, again, if you're in an emergency situation, so those of you, for instance, that have referring hospitals, or those of you that are in systems where your larger hospitals are filling up their acute beds with COVID patients and they need a post-acute setting, they can, without the 3-day required acute stay, move them onto your swing bed. But remember, it does have to be in the pandemic rules, and there has to be COVID patients there. The second part of this is doesn't mean you have to take COVID-19 patients. You can be taking the heart attacks and the IV antibiotics for C. diff and the orthopedic that were emergent for some kind of reason. You can take those patients. And so what I'd like to really point out here, and it goes down towards the bottom of this slide, which is you have a choice right now how you're going to use your swing beds. I actually have one facility that's not going to admit swing patients. They made the decision that they didn't have any COVID-19 and they didn't want to bring in COVID-19 swing bed patients. That's 1 out of maybe 100 that I've talked to already this month. So it's very rare. But I do have facilities that have worked out with the larger referring hospitals to take all of their non-COVID patients. So again, where are the heart attack patients, all of those going to go? And they're taking those kinds of patients and admitting them. So they've amended their admissions criteria to fit that. There are others that are taking all COVID. The problem you'll get in is if you try and mix them, because the rules are very, very clear that you should have a team set up just to deal with the COVID patients. And actually, if you have all COVID patients and you have a fair number of them, and you have two teams of nurses and aides and whoever else dealing with those patients, they shouldn't intermix. There are room numbers or patients by definition that should be set to one team, and then another set of patients and or room numbers to a second. And those two teams shouldn't intermix. They're again, you know, all the infection control rules. Just put infection control on steroids right now and figure out how you're going to try and keep it safe. I've recommended from the beginning, if you can, you need to take your swing beds and put them down a hallway, or better yet, around a corner, away from your acute patients. Remember, your acute patients are going to be coming in and out, and if you're taking COVID-19 patients, you're going to have quite a turnover of those, while your swing bed patients could be staying longer than the COVID patients, depends on where you are in that process. I think there are several of you in Indiana that are in your swing bed and acute have been taking vent patients. In that case, obviously the length of stay for acute and for your swing beds is longer than whatever normal might be. And you know that the 96-hour rule was suspended if that's the case there. So we have lots of things that are going on with that. So bottom line right now is the 3-day waiver has been granted to the critical access hospitals, at least from 2 documents that I've read today. And by the way, Becky has one of them in her hand. So if any of you get surveyed or question about it, there is a copy of that document within your team in Indiana. The other thing I would like to bring up is dementia patients. I've been kind of interested in following several, not only swing beds, but some of my nursing home clients about how dementia patients are dealing with it. There's huge, huge worries in the nursing homes that we're going to have failure to thrive deaths because we've had to isolate people to their own room, and dementia patients either are very happy in their own room or very unhappy in their own room. And so that has been difficult. And it's come to mind this week because if we didn't have enough going on the earth right now, the tornadoes that just whipped through the South actually took out an assisted living facility. I think it was in Mississippi. But anyway, they had to transfer in the middle of the night, and they were 100% dementia Alzheimer's patients. They found an embassy inn, hotel, whatever it was, suites. I think it's Embassy Suites down the road. They, in the middle of the night, started pulling people out of rooms. Their roofs were torn off, the windows were broken, putting them in a bus and transporting them down, putting them in a new hotel room, which is obviously something they hadn't seen before. And they're trying to manage over 50 patients. And that made me stop again to think about, just because we have COVID-19 doesn't mean we aren't going to have dementia patients that have difficulties with that disease, or they're going to have family members that they're concerned about. So please consider that. And there's a good resource at the Alzheimer's Association just specifically on how to deal with dementia patients during this kind of trauma. So you might want to look at that. There is a new memorandum that came out. I'm giving up on dates. I think this one was on 4/13 about the disposition of hospitalized patients. I have sent that on also for you to look at. Actually, it's March 23rd was the original. I think 4/13 was the secondary one. But I've sent the March 23rd one, I think, is the one I sent on to Becky to forward to you, because there's a really nice summary about halfway down the page, I think, that says very clearly that you can discharge them to a health care facility whenever indicated. And so it talks about how we're going to test when to discharge patients. And it's like I think it's a 3 or 4 page document that you may want to read. And the same thing, just this morning, We got an update that was, well, it was released this morning. It was dated for yesterday. And I will tell you that one I just sent to Becky, but it's the QSO, in this case, QSO-20-25 nursing home or NH. This is not only got a 2-page memorandum on how we can move patients and transfer patients around. It has 3 pages of graphics. Somebody has taken some time to draw pictures of how you can move them from a nursing home to hospital or nursing home to home and so forth. Normally, we have not been able to transfer patients without some notice to those that were getting transferred, and all that's out the window right now. Facilities that need to transfer residents within a facility to another long-term care facility, or in certain cases, there are non-certified locations that have been designated by the state where we've had to add rooms. You can transfer patients at any point that is needed, as long as you coordinate between the facilities. The other thing that you're going to need is you're going to have to work with your the state for sure, but certainly local community members as we are trying to move people around who have been diagnosed with COVID and those who are presumptive COVID. So the blanket waiver in this case is that we are also being allowed to temporarily use rooms that aren't normally a residence room. I've got 2 facilities right now. One's using it's a private dining room. And another one's using a conference room with overflow patients at this point. One of the problems that nursing homes have, and why we have had some difficulty transferring out of acute and possibly swing bed to nursing homes, really is 2 things. One, if you see the total number of nursing homes with COVID patients, nursing homes are really, really nervous about bringing in somebody when they have a population already living there who has not had signs of COVID-19. So they're trying to avoid that. The second thing is, in the documentation from about a week ago, CMS strongly suggested that if you take admission in a nursing home, that resident or patient resident has to be isolated for 14 days. Nursing homes just don't have those kind of rooms. They can't be returned to their own room where there's another nursing home resident unless they have, and I wouldn't even say they're even trusting the testing negative at this point. Some of those are failing. So the only way you can cohort 2 nursing home residents at this point is if they've both tested positive for COVID-19. That's limiting their beds, and that's why I think swing beds are getting ready to get caught up in the middle of this, and have already in multiple states where they're kind of getting hit very hard by people needing an admission place. So that document I just sent to Becky. She'll get it out to you, I'm sure. And then the other thing that I sent on this morning was COVID-19 billing. It is just a summary item that was put out on March 18th on how to bill for different settings. It's got a lot of information in it that may help your billing department if they're having trouble finding information too. And the final thing sort of tied to billing is there is a COVID-19 ICD-10 code now. I'm going to misquote it. I'm actually going to misquote it. I'm not going to say. I think it's somebody else can do it. U02 point. I'm not even going to say it. Please look it up because my brain is dead already. I only said that about 20 times yesterday. So the rule with that is you must use it if the person has COVID-19, even if they've come in because they have a fractured hip. At this point during the pandemic, anyone being admitted to any of our settings, whether it's acute, swing bed, or otherwise, needs to have the COVID-19 code that has been sent to you. We are not to use the 0.1 code. We are to use the 0.2 code. And the reason we're not to use 0.1, that is the World Health Organization set that up to work around the world to have a common ICD-10 code. And for some reason, it did not work in the US, so we are using a 0.2. And I will tell you that the importance of using that on any COVID patient is that's how the federal government is tracking the total numbers ultimately and outcomes for those patients. So it's important that you use that. And then as far as the use of swing beds, that was a generic statement. Again, please make a decision on probably taking all COVID or all non-COVID patients and not trying to intermix them in your swing beds, unless you do like several of my clients have done now, where they're running 20 and 21 swing bed patients. And they can split them by wings or hallways. So with that, Becky, I think I've left about 10 minutes. If there are any questions, and I hope this made sense and helped some people kind of think through some things. Okay, Becky?
Can you hear me now?
I can hear you now. I was thinking, have I been talking to myself?
No. I do have a question for you. The waiver, does that apply to direct admits from the emergency department to nursing homes instead of the qualifying stay in the hospital? Just for clarification.
They have not said anything about that specific. Let me look quickly through this thing that they just released on that. They have not said that specifically. They have only been talking about they're coming from acute. I think it's a good question. It has been asked several times, but I'm still trying to read through this, but I have not seen anything with that language in it. Actually, there's an office hours tonight. Let me see if I can get that question onto their docket and see if they say anything about it. We'll get an answer back to you.
Perfect. Thank you. Appreciate that. That was the only question that I had received here. The one question I had is that you mentioned, you mentioned the admissions criteria needing to have some statements related to COVID-19 or pandemic, I guess, more specifically. Are there other policies and procedures you think that should immediately be reviewed to include that type of language, or any recommendations there?
Yeah, well, I'll go back to those two assessments I've recommended. So one is going up through your emergency preparedness plan. Pandemic was always supposed to be part of that. We've never really stressed that when I've helped write them. We've been talking about tornadoes and snowstorms and hurricanes and that sort of thing. But the other one really is look at your infection control. You need to make sure that you're following those rules very, very carefully, whatever your policy says. And you need to see if it's been updated for, or already had a paragraph in it about a pandemic situation. Because, for instance, one of the things now is that, like the PPE, and not being able to find certain PPE, then what's your policy on what you're going to do when that occurs? So I know your hospital's probably already done that, but you should make sure that your swing bed staff is aware of that, and that your specific swing bed policies, if you have one on infection control, should address that.
Thank you. The other question that came in is, how have some other critical access hospitals developed patient stories to be able then to market the swing bed programs in the future? Okay, so this is up and beyond pandemic, do you think, Becky, is what that question means? It could be. It didn't say that specifically, but it could be. Well, certainly you can market if you get through this pandemic and have good stories where people have gone home. I mean, I have been watching rarely, but I try and catch about 10 minutes of the news in the evening, just because I want to see whatever the latest states are. Like I'm in Florida, and we're getting ready to go into our 2-week height of our period on this. But I've been surprised how many pictures they have shown of patients leaving hospitals. And my little brain is going, oh my God, HIPAA. So hopefully they got them to sign off on something. But there's such excitement when, and hope when we see people leaving the hospital. I think the guy that was shown last night had been in the hospital for 25 days. And people are lined up as far as staff and, you know, cheering, and that's how important it is that we're getting some people home. I think those kind of stories, even post pandemic, would be
good stories for your community and for your referring hospitals. But more specifically, when we're looking at how we're going to market, this is probably a discussion where Becky and I need to set up a more in-depth webinar on it, but you need to look at particularly maybe a specialty that you do that nobody else does in rural areas. You may have specialists or people that you can show the work that is being done in conjunction with your acute and your swing bed to larger referring hospitals. You really, really want to be tracking, let's say XYZ hospital in a large city has been referring patients to you. You want to be able to send back information on the outcome of those patients in particular, that they went home and that they stayed out of the hospital for 30 days, because remember those larger hospitals are getting penalties. And this is the unique things that you were able to do for that patient. Those make great patient stories. And then the other piece of it is just anything that you're doing team-wise. That may be a little different. So, for instance, under the the PDPM, though I know you're not under PDPM, one of the things that was added in is speech working with dietary on morbidly obese, malnutrition, and mechanically altered diets. We have a lot of malnutrition in this country. It's not something that we do a lot of discussion on. So there is a type of topic that you could take, and as your team is evaluating the patient and finds out they really should have a malnutrition as a diagnosis, getting that diagnosis, and then what are you doing that's creatively helping those patients go home and take care of themselves. So I think it's where you can stand out in the crowd, but I also think at the same time, whoever has been sending you patients, you need to tell those patient stories back to that referring source.
Thank you, Kerry. A question in the chat. Has any nursing homes been requiring that their residents have a COVID test done and resulted as negative before accepting them back? If so, can you place them in Swingbed until the test comes back? Good question.
Yeah, it is a good question, and it's a complicated one because we're beginning to see the numbers of failures on the ones that are coming back negative. So, and I don't know, I think it was up to 11% or something yesterday. So that gets a little dicey. So I haven't seen that exactly from my nursing home. So my nursing home clients are really in two categories. One is that they're not taking admissions, and that's basically now for all the ones that I'm working with because they have no beds available. They don't have a place to put somebody in isolation for 14 days. And the other thing is none of my current clients have COVID patients in their nursing homes right now, and they'd like to keep it that way. They're being very careful as staff goes in and out. So I think we're going to have to watch each of our own. In fact, I've been recommending to case managers, you really need to almost be talking to the nursing homes daily to figure out if they're going to be taking any admissions. The CMS translation of that is that they should take admissions, in the same breath CMS says, but we can't enforce that. The reality is a lot of them don't have beds. A lot of them are afraid that they will infect their own staff and thus their own populations in the nursing homes. And then a lot of them don't have rooms. So the backside of that is, can you take COVID-19 patients in a swing bed? And the easy answer is yes. Just remember that first part, remember the rules. They still have to have a qualifying for a skill level care. So in this case, they may need, probably 99% will need respiratory care. They may be on IV antibiotic, for instance. There are a lot of things that you can qualify under Part A, and just remember to make those qualifiers and not just use the word COVID-19 as a reason to put them in your swing bed.
Okay, thank you, Kerry. Another question that came through is, are there specific list discussion groups on QualityNet that you recommend being signed up for beyond just the hospital? And I think probably where that stems from is like skilled nursing. Should they sign up for those, or is that too much information?
Well, I have people that have signed up for skilled nursing. The nice thing about signing up for skilled nursing is sometimes you realize what's going on survey-wise in your state or in your region, and that can play out to you, because swing beds were certainly, before this hit, beginning to get more surveys. I think I work a lot in Iowa, and I visited, I think, 22, 23 of their critical access swing beds last year, and 20 of them had been surveyed in the last year. So it's going kind of state by state, but beginning to hit. So that might help kind of with the nursing homes, let you know what topics are the main topics that a state survey team is looking at. You are under, technically, long-term care and skilled rules. As we've talked about, they didn't separate that. The issue is, if you were a PPS hospital, then you're more directly related, because there'll be a lot of discussion on those listservs about PDPM. You would have to kind of get out of the ground level discussion on PDPM and look at up from the helicopter view at, what does this mean for me? In other words, what's the main thing that CMS is hunting, and what can I do in my own facility to try and match what CMS wants? I know some groups have people in their nursing homes that get on certain listservs, so it may be just for activities, it may be just for quality improvement and so forth. If you have that kind of separation, that might be helpful for you too.
Okay, thank you. Well, that ends our time for today. Again, if you have specific questions, forward those to me. We will facilitate getting them answered for you. The state is doing their best to provide feedback and answers to questions, and Kerry is providing regular updates. And again, I encourage you to watch for emails from Joyce Fillenworth. She has been sharing information on funding opportunities for critical access hospitals that have resulted out of the pandemic. So please take note when you see those emails come across your inbox. So thank you, stay safe, and we certainly appreciate everything you're doing for the patient. Thank you, Kerry. Thanks, Allie.
You're welcome.